All right, let's dive right into the agenda for this explainer. First, we'll hit the Borrmann classification itself, then management principles. After that, a key clinical pearl, a classic exam trap to watch out for, and we'll wrap the whole shebang up with a quick recall question.
Okay, Part 1, the Borrmann classification. This is the absolute foundation of macroscopic staging. Now, before we just blindly memorize the types, we really need to understand what this actually measures. The Borrmann classification is a system that describes the macroscopic appearance of advanced gastric carcinoma. And guys, the crucial word there is macroscopic. We're talking gross morphology here. What does that tumor look like to the naked eye when a surgeon opens up the stomach, or what does the endoscopist see on their screen? We are not looking through a microscope yet. It's all about the gross structural appearance of the lesion.
All right, here's the actual system. This breakdown is your high-yield cheat sheet right here. There are 5 types, and examiners absolutely love to test your ability to tell them apart. So, starting with type 1. This one presents as a polypoid or fungating mass. Picture a distinct, bulging growth just protruding right into the stomach lumen. Then, type 2 introduces ulceration. It's an ulcerated lesion, sure, but it has very well-defined raised margins, kind of like a crater with really distinct borders. Now, type 3 is also an ulcerated lesion, but here is the pivot. It's got infiltrative, poorly defined margins. The border between the tumor and the healthy tissue is blurry. It's actively invading outward. Then there's type 4. This is the one that strikes fear into the heart of any surgeon. It's a diffusely infiltrative lesion, famously known as linitis plastica. The whole stomach basically becomes rigid and thickened, like a leather bottle. And finally, type 5. That's just your unclassifiable category, reserved for lesions that simply don't fit neatly into types 1 through 4.
You know, it really helps to build a mental timeline of how this disease progresses macroscopically. Think of it like steps. Step 1, type 1. You start with a localized, distinct mass. Step 2, type 2, the center of that mass necrosis, so you get an ulcer, but those margins are still clear. Moving to step 3, type 3, that ulcer starts aggressively invading the surrounding tissue, so your margins get ill-defined and infiltrative. And finally, step 4, type 4, that localized structure is just entirely gone. It's totally lost to diffuse infiltration, giving you that dreaded rigid stomach. Viewing it as a spectrum of worsening gross invasion really makes the clinical picture click.
Moving on to Section 2, Management Principles. Let's talk about translating this classification into real-world action. Okay, here's a hard truth that constantly trips students up on the wards. The Borrmann type itself does not determine the treatment. It's just a descriptive tool. Management depends on a way broader picture. You need the TNM stage to gauge anatomical spread. You have to assess resectability. You got to evaluate patient fitness, like can they actually survive a major operation? And crucially, you need the histology and molecular characteristics to understand the biological behavior of that tumor. The gross appearance is just one piece of a giant, multidisciplinary puzzle. So when we gather all those puzzle pieces, the stage, the fitness, the molecular profile, we generally split management into a few distinct pathways. For resectable disease, the absolute gold standard is an oncological gastrectomy with appropriate lymphadenectomy. That means removing the stomach and clearing out those associated lymph nodes. Plus, perioperative systemic therapy, meaning chemo before and after surgery, is often used for locally advanced cases to shrink the tumor and hit micrometastases. On the flip side, for unresectable or metastatic disease, systemic therapy is your primary modality. And hey, we can never forget palliative treatment. If a tumor can't be cured, our aim immediately shifts to managing symptoms like obstruction, bleeding, pain, and nutritional compromise. Quality of life is always paramount. Which brings us right back to why Borrmann type 4 is such a massive clinical deal. Type 4, that linitis plastica, is often so incredibly extensive and diffusely infiltrative that it's frequently super difficult to resect with any curative intent. Because it spreads so stealthily right through those submucosal layers, what you're seeing on the surface is almost certainly underestimating the true extent of the disease. So managing a type 4 lesion requires meticulous, careful staging and rigorous assessment of resectability before you even think about taking that patient to the OR.
All right, Section 3. This is our key clinical pearl, the critical distinction.
Now, what's really interesting here, and honestly the most important distinction in this entire classification system, is the difference between type 2 and type 3. Look on the left, type 2. Yes, it's an ulcerated lesion, but check out those margins. They are well-defined and raised. Now look on the right at type 3, also an ulcerated lesion, but the margins are infiltrative and poorly defined. Why does this matter so much? Because that margin literally tells you about the tumor's local behavior. A poorly defined infiltrative margin means you've got a more aggressive local spread that's blurring the lines between diseased and healthy tissue.
You absolutely must have this distinction locked down for test day. Which leads us nicely into Section 4, the classic exam trap. Let's protect your score. What we're looking at here perfectly illustrates a trap you absolutely need to dodge. Do not, under any circumstances, confuse Borrmann type 4 with the Laurin diffuse type. They sound similar, right? And they're conceptually related, sure, but they are completely different classification systems. On the left, Borrmann type 4 measures gross morphology, what the tumor looks like to the naked eye, your diffuse infiltrative gastric carcinoma, your linitis plastica. But on the right, the Laurin diffuse type measures histology, what it looks like under a microscope. That's your poorly cohesive or signet ring cell carcinomas. Borrmann equals gross morphology. Laurin equals histology. Keep those firmly separated in your head, and you'll dodge a major exam bullet for sure.
Okay, let's wrap this up with Section 5, a quick recall question to test your knowledge right now.
Here is the scenario. A gastric carcinoma appears as an ulcerated lesion with poorly defined infiltrative margins. Based on what we literally just went over, what is the Borrmann type? Take a second, think about those margins.
All right, if you said type 3, awesome job. The absolute dead giveaway there is the phrase poorly defined infiltrative margins. Remember that key pearl we talked about? Type 2 has those clear, well-defined margins, while type 3 is poorly defined and infiltrative. Nailing that means you've totally grasped the macroscopic nuances of this disease.
So you've got the gross macroscopic staging down. But as we said earlier, Borrmann alone doesn't dictate the cure. I want to leave you with this final, provocative thought before your next study session. Beyond the macro, how do the histology, like that Laurin classification we just touched on, and the specific molecular characteristics ultimately dictate the final, personalized treatment path for a patient? The macro gets you started, but the micro? That's where modern oncology truly happens. Thanks for joining me on this Rapid Review Explainer. Keep studying smart, and I'll catch you in the next one.